Welcome, everyone. Thank you for joining us today. My name is Carrie Grady-Vincent, and I am the Senior Manager of Scientific and Clinical Programs here at Osteoporosis Canada. I will be your moderator for today's webinar, Common Questions about Osteoporosis and Drug Therapies. Before we begin, Osteoporosis Canada acknowledges that the land our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. At Osteoporosis Canada, we educate Canadians about bone health, including healthcare professionals and their clients. We are the only national organization serving people who have or are at risk for osteoporosis. The organization works to educate, empower, and support individuals and communities in the risk reduction and treatment of osteoporosis. We are excited about today's presentation, which will provide general information about osteoporosis and drug therapies. It is not intended as individualized health advice. If you have questions on osteoporosis drug therapies, please consult your own healthcare provider. If you have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can in time permitting. So before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. It is now my pleasure to introduce our speaker, Teri Charrois. Teri worked at Grey Nuns Hospital in Edmonton in internal medicine for several years before completing her master's degree in clinical epidemiology in 2005. Teri then worked as a research associate in the Faculty of Medicine, coordinating research studies in pharmacy practice. Currently, Teri holds the position as clinical associate professor and Director of Practice Innovation in the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta. For her clinical practice, Teri works in a multidisciplinary osteoporosis clinic once a week in the Division of Rheumatology at the University of Alberta and is an active member of our Scientific Advisory Council. Without further ado, I'm going to turn things over to Teri. So Teri, please take it away.
Thank you, Carrie. I'm just going to share my screen here. All right, welcome everybody. I'm going to go through some questions that have commonly come up in my clinic when I see patients, and also questions that have been forwarded to me from Osteoporosis Canada. And then we will have some time at the end for some general questions, but again, as Carrie mentioned, nothing in terms of, it's not meant to replace any information or questions you can get answered by your own healthcare professionals. So we're going to go through a few common questions. Like I said, these are ones that I have normally come across in my own practice. The one I get asked probably the most often is, how long will I have to take this medication for? We're going to talk about which medications work best for osteoporosis, side effects that might be concerning to people before starting therapy or after being on therapy for quite a while. Another one I get asked very often, can't I just take calcium instead of my medications to help with my osteoporosis? What medications should I be avoiding if I have a diagnosis of osteoporosis? And how should I take my medications to make sure they work the best that they can? So we have three groups of medications that we generally use for osteoporosis. And I thought I'd start here before I get into the questions, just so we're all on the same page. So we have medications that slow bone removal. So these make, so our body always takes away old bone and puts down new bone or builds new bone. And what these medications do is they help slow bone removal. So when our body wants to take away old bone, these medications stop that. So these are the commonly used medications called bisphosphonates. That include the ones we normally see are alendronate, risedronate, In the olden days, we used to use something called Didrical or Atidronate. We don't use that one anymore as it's not effective, but these are the newer ones. And then also denosumab, which is one of the injectable medications, or Prolia. So these all slow bone removal. Then we have medications that build new bone. So these actually lay down new bone. And the one medication we have in that class is called teriparatide or Forteo, and it's an injection given every day. And then we have some, that work both ways. And these medications are, this medication is called romosozumab. It's the newest one on the market, or Evenity. And so it slows bone removal and builds bone. So it works in both ways. So this is just a diagram of that. So you have your body helps remove old bone, and it also helps lay down new bone. So those medications can work on either of these pathways or on both. All right, so the question we commonly see, and in the questions I was provided from Osteoporosis Canada, this one came up. How long will I have to take this medication? How long am I going to have to be on this medication? And obviously, it's a really individual question that has to be answered based on your own personal risk factors, your previous history of fractures, your family history, and a lot of different factors that come into account. But part of this is related to whether or not a patient needs to go on what we call a drug holiday. So no, it doesn't mean you get to go to a beachy vacation and pack your sunglasses, but what it means is you get to be off your drugs or your medications for osteoporosis for a few years to help reset your bone work, the laying down new bone and the taking away old bone for a couple of years before we put you back on medication. So that's what a drug holiday is. So we consider drug holidays in patients who've been on therapy generally 3 to 5 years after they've started therapy, and not always with all the medications. Only some of the medications do we actually consider a drug holiday. Some of the medications we can only use for a short period of time. So the newer medications, such as teriparatide or Forteo, we can actually only use that for 2 years. So when we stop it, it's not a drug holiday, it's that you're off that medication. And then the newest agent, romosozumab or Evenity, we can only use that for a year and then we have to stop it. But with bisphosphonates, we often consider a drug holiday. So it really depends if we take you off your medications, or it depends how long you're going to be on your medications for based on your risk classification. So when we see patients in our clinic, we always measure their risk classification based on a number of different factors. We consider your height, your weight, how many fractures you've had, what other medications you're on, if you smoke, how much you drink alcohol, and what your bone mineral density is. And then using these calculators that they're called, you may have heard these before, they're called FRAX is the one we often use, and there's also CAROC, and that puts you in a category. You're either low risk, moderate risk, or high risk. And generally, again, not individual information, but if you're low risk, we generally don't treat. If you're moderate risk, we can treat depending on other risk factors, and we can consider a drug holiday. If you're high risk, we generally treat long-term and don't consider a drug holiday. But again, there are exceptions to that. And we consider those drug holidays 3 to 5 years after being on therapy, depending on your risk classification. How we weigh the risks and benefits of stopping therapy is really related to what your risk of having an adverse effect or a side effect related to staying on that medication. So if you're getting alendronate and you've been on that medication for a long time, it puts you at risk of unusual fractures in your thigh bone. And the technical term is atypical femoral fracture. Now, or AFF. You may have heard this when you've talked to your physician about this, or when you've talked to your pharmacist. And these occur generally in patients who've been on therapy for 10 or more years. That's why we try and reassess therapy ongoing every year and really think about stopping after 3 to 5 years in certain patients. It seems that they occur in certain patients. We find in very small, petite women, we have a higher rate of atypical femoral fractures. And then in some ethnic groups, there may be an increased risk as well. But we have to weigh that risk of having these unusual fractures with what is your risk of just having a fracture because you have osteoporosis. So that's related to that risk classification I talked about. That's related to how likely you are to fall. So if you have an increased fall risk for lots of different reasons, if you've had a previous fracture or not, and by previous fracture, I mean a previous fracture due specifically to osteoporosis, so a fragility fracture, and what your current bone mineral density test. So that's that test where we determine how strong your bones are. So bottom line with this is never stop your therapy without discussing it with your prescriber. And it's a discussion you should be having. You should get, your therapy checked at least once a year. And then consider other ways that you might be able to increase your bone mass. And unfortunately, calcium alone doesn't do that, but things like weight-bearing exercise is one way where we can do that, ensuring you have enough protein in your diet. But those are obviously outside of my specialty and something you should discuss with your prescriber if you have a physiotherapist or if you have a dietitian. So another question we often get asked is, what medication works best? I want to be on the medication that works the best. What should I be on? And every province is different in what they cover. So what we cover, I'm in Alberta, so what we cover in Alberta is actually different generally than what they cover across Canada. But overall, we start with bisphosphonates, such as the alendronate or the risedronate, because they do work well. They're relatively inexpensive and they're relatively well tolerated. So they often are where we start for therapy. We do know that all the medications we use now, so the medications I talked about right at the beginning, all reduce your fracture rate. So they all reduce your risk of having a fracture in the next 5 to 10 years. And what we choose for people, or what we discuss with people, depends on if they've tried anything in the past, what your individual risk of side effects are based on maybe what you've tried in the past or other medications you've been on. If you're on a medication right now and your bone mineral density, when we check it every year or every 2 years, if it continues to drop even while you're on therapy, so if it continues to get worse, we can maybe change your therapy. Or if you've had a fracture while on your current therapy. So if you're taking something like alendronate right now once a week and you have a fracture while you're on it, we may need to consider changing it to something else. So those are the things we think about changing it. But the bottom line here is that all medications will reduce your risk of having a fracture in the future. The newer agents are significantly expensive, namely teriparatide, and it depends on a patient's individual drug coverage, and that's something that can be explored with your prescriber. Not all patients need to be on these, fancy new drugs that build new bone. So if bisphosphonates work for you and you've been on them and they've prevented you from having a fracture and you've had a fall and didn't fracture, that means it's working for you. Your bone mineral density is staying stable. It's working. We don't need to change it. All of these things, again, relate back to that risk classification. So when we see what risk level you're in, that can play a part as well. So your therapy will work, trust in the therapy. And like I said previously, it needs to be reassessed every year and you should be getting your bone mineral density. In Alberta, we do it every 2 years for most patients. High risk patients, we might do it every year, but it depends on your province as well. But every 2 years is a generally reasonable amount of time to get your bone mineral density reassessed and then your drug therapy reassessed every year. All right, so another question we often get in the clinic is, what side effects should I be worried about? So what things can I expect, or what things might be unusual or rare that could potentially happen while staying on therapy? So most commonly with the bisphosphonates, again, this is alendronate and risedronate, most commonly what we see is stomach side effects, so upset stomach, some patients even vomit related to that. If it's ongoing, we might need to rethink that therapy. And then we also see bone and joint pain. So patients complaining of bone and joint pain after starting these medications. Less common side effects that can occur, but are rare, that atypical femoral fracture. So that's what I talked about with regards to drug therapy or drug holidays. So that's where you get an unusual break at the top of your thigh bone. So I always tell patients, if you've never had pain in your thigh before, and all of a sudden you get a sharp pain at the top of your thigh, you need to go to emergency. You need to see somebody right away to make sure that's not an atypical femoral fracture. In terms of issues with osteonecrosis of the jaw, and what that is, that's fancy words to say we decrease the blood flow, or the drugs decrease blood flow to your jaw. This is something that is often rare. We see it in higher doses and after patients have been on it for a long period of time. So these medications can all be used for different types of bone-related side effects related to cancer therapy, and we use much higher doses in those cases. And that's generally where we've seen osteonecrosis of the jaw. It's something you should tell your dentist if you're on one of these drugs. Just mention to your dentist that you're taking it, but get your regular dental work and teeth cleaning and do what you can. It's more of a concern if you need to get teeth pulled or any other major dental work. These medications can also lower your calcium levels, but not something we generally check on unless you have symptoms of sort of muscle cramping, which is different than that bone and joint pain. And then we could test your calcium levels to see, but this is why we also want to make sure you're getting enough calcium in your diet. So denosumab or Prolia, so it's an injectable medication. It's giving sub-Q, so an injection just under the skin every 6 months. Patients often feel unwell, especially after that first injection. It seems to go away the longer they've been on it, and just kind of more feeling like you have a bit of the flu. You will also potentially see some bone and joint pain as well with this. That again goes away with therapy. You'll notice a common theme here, very similar side effects to what we see with the bisphosphonates in terms of that unusual fracture of the thigh bone, the osteonecrosis of the jaw, and low calcium levels. And everything I said about bisphosphonates apply here. So making sure if you do have acute pain at the top of your thigh, seeing your prescriber, going to emerge, making sure your dentist knows that you're taking this medication, and then informing your prescriber if you have any kind of muscle cramping that occurs, which is related to low calcium. The other thing that is speculated with denosumab is it may increase your risk of infection, although it's thought that it might do that, but we haven't actually seen that much in practice. So it's not something we generally worry about, but it might be discussed with you, and it's definitely not. We haven't seen a huge increase in our patients we see in our clinic in terms of infection rates. So romosozumab, so that's Evenity. So this is given as a sub-Q injection every month. And it's the newest agent, and it works both at building new bone and preventing old bone from going away. Bone and joint pain, again, with this medication, along with headaches, although headaches are less common than the bone and joint pain. What we worry about most in terms of less common things is we have concerns in patients who've had a history of a heart attack or stroke. We do not use this medication in those conditions if you've had a history of those conditions. Because in some of the studies or the trials used with Evenity, it actually showed to potentially increase the risk of heart attack and stroke. The data is still unclear with regards to that, so we're not entirely sure, but it's something we generally avoid use in those patients. Again, atypical femoral fracture, the osteonecrosis, low blood flow to the jawbone, and low calcium as well. With teriparatide, so this is a sub-Q injection every day for 2 years. We see some dizziness, again, stomach upset like we do with bisphosphonates, and muscle cramps. We, in our clinic, do recommend routine monitoring of blood work in terms of the calcium levels. So that's something we generally monitor with this drug. We do with Prolia as well, because Prolia, which is denosumab, also can drop your calcium. In this case, it can increase your calcium. And then the reason it's limited to 2 years use is in some of the studies, and this was only in animal studies, this has not been seen in humans, was that it increased the risk of bone cancer in mice. Keeping in mind that they used whopping huge, massive doses of this drug in these mice studies. We have not seen this in practice, but it is the reason Health Canada only allows us to use it for 2 years. So how can we manage these side effects? So if you're getting a side effect with a medication you've just newly started, it does often go away with use. So it's something we recommend just trying to stay on the medication if possible, and then seeing if it does go away. Discussing it with your doctor or pharmacist to make sure it's not anything unusual or unexpected. And if it's not manageable, definitely needs to, therapy needs to be reconsidered. So if it is manageable and it's just somewhat annoying, I know it's easy for me to say, oh, just keep taking your drug. But if you can manage it, we would recommend staying on your therapy. It's when it becomes unmanageable that we would consider other therapies. All right, so the next question we often get is, can't I just take calcium to help my bones? Like, do I have to go on a medication? Why can't I just take calcium pills and all is good? So our number one reason why we put people on drug therapy is to prevent fractures. So we recommend not using, calcium on its own is actually not going to prevent fractures at all. It helps your bones, it helps your body use the medications as best as they can, but calcium in and of itself is not going to prevent you from having a fracture. So we always want to make sure you take enough calcium and vitamin D, and our dietitian in our clinic works through that with everybody, but it won't actually prevent you from having a fracture. So that's why we don't recommend calcium or vitamin D alone. It's important that your calcium requirements are assessed if you have osteoporosis. And in most people over 50, we recommend 1,200 milligrams a day of calcium. We always recommend, if possible, calcium through your diet. And where that can't be achieved for lots of different reasons, lactose intolerance or just diet restrictions or whatever, then we will recommend supplements. Different calcium supplements have different amounts of calcium per tablet. Calcium carbonate, which is generally the big horse tablets, they're often green or white, quite chalky tasting and feeling. They have the most amount of calcium per tablet, and they have to be taken with food, but they don't always work well for everybody because they can interact with some medications. And if you're taking more than one tablet at a time, no matter what the calcium, we do recommend you splitting it up over the day. It just helps with the absorption, so you absorb more. And then supplementary to that calcium is obviously vitamin D. So Osteoporosis Canada recommends everybody in Canada, everybody should be getting vitamin D supplementation. We just can't get enough. In Canada, mostly because we're in the dark for a good 6 months of the year. So in people over 50, the daily recommendation is anywhere from 800 to 2,000 units a day. So it's definitely something you should discuss with your prescriber or your dietitian. We usually recommend 2,000 a day, but not everybody needs to take that. So what medications might actually interfere with your osteoporosis medications or make your osteoporosis worse? So there are a list of commonly used medications that have been found to either make your osteoporosis worse, so have an effect on your bone mineral density, or increase your fracture risk. Number one of these medications is prednisone or glucocorticoids or steroids. And we can use these medications for a bunch of different things. We can use them for different types of arthritis, for different breathing problems, different kind of immune related conditions. So patients who are on prednisone or glucocorticoids should be assessed for their risk of developing osteoporosis. It's something that needs to be definitely assessed by your physician. Lots of the breast cancer and prostate cancer medications can also decrease your bone mineral density. We see a lot of these patients in our clinic. So it's often you use steroids as well, or prednisone in addition to these breast cancer and prostate cancer medications. So it needs to be assessed appropriately to determine if anything else is needed to help you prevent developing osteoporosis. Some seizure medications can increase your risk of osteoporosis. Generally, that's related to a vitamin D deficiency. So it's something we always think about when we check somebody's vitamin D level. So that's a blood test that can be done if they've been on long-term seizure medications. Commonly used medications for ulcers or for reflux are called PPIs, or proton pump inhibitors. So we think about things like Losec or Pantaloc. Excuse me, they can also increase your fracture risk. They can also affect how we absorb calcium through our gut. So we always recommend not staying on those medications long term if you don't have to. And then some water pills or diuretics that are used often for blood pressure control can decrease our calcium absorption, which can in turn potentially cause problems. Now, having said all of that, if you're on any of those medications, do not stop them. You need to discuss this with your doctor, and often that can be managed. So, we can manage you developing osteoporosis if you're put on prednisone by considering other therapies. So it's really important that you don't stop any of these medications, but it could be a discussion you could have with your physician. Some of the research is really hard to interpret, so we think it might increase your risk, but it's not really great research, so we're still learning a lot about that. And I think this applies for any medications. Only take medications for which there's a clear and ongoing need. So if you've been on something for a really long time and you might not have that condition anymore, discuss it with your prescriber and see if you need to continue taking it. All right, how should we take our medications to make sure that they work the best that they possibly can? And it depends on the type of medication. So bisphosphonates are oral, so we take them orally once a week. Usually there are once a month ones out there as well. Generally recommend to take 30 minutes before eating, with most of these regular once a week ones, with a full glass of water, and not lying down after, because they can really affect our esophagus. So they can cause little holes to come in our esophagus. So that's why we say don't lie down after, because then if they sit in the esophagus and they're not going down to the stomach, it can cause these little ulcers. We recommend taking it on the same day every week. If you forget it, you can take it the next day, but never ever take 2 on the same day. So if you miss it and you don't realize till a week later, don't take 2, just take 1. You've missed a dose, it's okay. Some of the Actonel tablets are a bit different. So there's one, so this is different types of Resedronate. So Actonel DR has actually been specifically formulated to be able to take with food. So that's why it's different. And there's also Actonel that can be taken once a month as well. Not all drug benefits plan cover these other Actonels. We don't see it a lot in our clinic because lots of plans in Alberta don't cover it, but you may have different plans where you're from. You can also give bisphosphonates IV. And the bisphosphonate we give IV is called Solodronic Acid, given once a year. Can be given in a hospital setting, kind of in an outpatient situation, and you get an infusion of this medication over about 15 minutes. You have to make sure you have lots of fluids given with it, because it can affect your kidneys. It's a good choice if patients have a hard time taking the once a week, or if the once a week medications are causing a lot of stomach upset or nausea and vomiting, or if people forget to take their medication. So it can be used in those cases. It doesn't work any better than the oral medications, other than if you always forget to take your oral medication and you remember to get this once a year, then it works better because you're actually getting the medication. But bottom line is, if you were to take your bisphosphonate every week as prescribed versus this once a year, the efficacy is the same. They work to the same effect. So then we have other injectable medications. So these are all medications that are injected under your skin. So either you can be taught to give yourself these injections, or your pharmacist or prescriber can give these medications. So denosumab or Prolia is injected under the skin twice a year, so every 6 months. Most of my patients here in Alberta, their pharmacist gives it to them, but not all provinces can pharmacists do that. So you just need to check with your pharmacist, and if not, you can go to your family doctor's office and have a nurse administer it, or the family doctor. Teriparatide is injected under the skin every day. So that one, patients generally need to be taught how to administer it because it's not reasonable to have somebody administer that to you every day. The drug company that markets this does have a patient program where they can help teach patients to do that. So that's something we generally sign our patients up for, to ensure that they know how to give it appropriately. And it's only given for a max 2 years, like I mentioned before. And then romosozumab or Evenity, it's injected under the skin once a month. The injection fluid is quite a bit. So it actually comes in 2 syringes, and you have to inject both syringes once a month because you can't give it all in one needle, basically. And that one can only be used up to a year max. So these are all injections, again, that are given under the skin. So things we always recommend in terms of taking your drug therapy is to ensure that you take your doses on time as best as you can. I mean, everybody forgets their medications at some point or another, and it's okay. And no judgment is what I always tell my patients. But the one we worry about the most is denosumab. If you are more than a month late with getting your Prolia or denosumab injection, it can increase your risk of having spine fractures, so fractures in your vertebrae. So it's something we are really, we ensure that our patients are really good at remembering to do and get that dose every 6 months as recommended. If you're having problems remembering, talk to your prescriber about ways to remember or other alternative medications that you might be able to remember better. Making sure you take an adequate amount of calcium and vitamin D every day. Whether you discuss that with your prescriber or a dietitian, but ensuring you're getting those. Osteoporosis Canada has some excellent resources available on their website. They have a calcium calculator where you can go in and put like what you eat on a regular day, how much calcium you're getting, how you could increase that through your diet, or what you could increase through supplements, so through tablets. And they also have some really good recommendations for vitamin D. The bottom line with vitamin D is no matter what we eat in our diet, it's not going to be enough. So that's why we always recommend 800 to 2,000 units a day for people. And if you are recommended to have blood work done, so like I say, we recommend blood work with Prolia, with teriparatide, and with Evenity or romosozumab, make sure you're getting that done. Sometimes we recommend it before a dose, sometimes we recommend it after a dose, sometimes we recommend it both before and a couple weeks after, but ensure you're getting that blood work done because that just helps us know that everything's working as it should. So those are just some general reminders. So that's my last slide, and I know there are lots of questions out there, so I wanted to allow enough time for that. So I'm just going to stop my share and then hand it back to Carrie.
Okay, thanks, Teri. That was great. Lots of information. You covered so many topics. We have received quite a few questions, so we'll try to go through some that weren't covered in what you were presenting.
Sure.
So let's start with a few. This may be sort of repeating, but I think it's a very good question. How is it decided at what point to start taking medication?
Yeah, good question. So generally when we decide when to start taking medication is if you have a diagnosis of osteoporosis and you're moderate to high risk. So that's where we use that risk calculator to determine where you're at. If you're moderate risk, we might in discussion with you decide therapy is appropriate, and for some of those patients we decide we'll just hold off and see. Most everybody who is considered high risk, we would start therapy. So it's not just based on your bone mineral density result. We look at a bunch of other things as well. So the bone mineral density helps us decide, but it's not the only thing. Sort of 20 years ago, we only used a bone mineral density as our determining factor for whether or not you should be on therapy, and that's changed over time. We don't have Osteoporosis Canada has some new guidelines coming out for management, and that it will be, again, not just based on that bone mineral density, but all those other risk factors you might have, and then where you're classified in terms of your risk.
Okay. This one again it's been covered a little bit, but I think it's another great question. Can you speak a bit about Prolia and jaw health? Jaw health.
Yeah, so yeah, it is a concern, but I re-emphasize that when we've seen denosumab causing problems with our jaw is when we've used it in a different form called Xgeva, which is actually the medication. It's the same drug, it's just in a higher dose, and we use it in cancer patients who have bone problems. That's the most common place where we see denosumab causing bone problems in your jaw. Having said that, it's important that you discuss with your dentist if you're on Prolia. It doesn't have a higher risk than any of the other medications, but you should discuss all of them with your dentist. Go for regular teeth cleaning. And if you are getting any major dental work done, it needs to be discussed with your dentist. Sometimes it's held for a period of time, sometimes it's not.
Okay. That's great. Actually, there is more information on our website too about jaw health too. So please look there for more information. Here's a general question. What blood tests do people get for osteoporosis?
Yeah, so there's different blood tests for diagnosing osteoporosis, and then there's different blood tests for monitoring your osteoporosis or your drug therapy. So generally, depending, when we diagnose osteoporosis in terms of blood tests, we do want to know how your kidney function is, because that can affect things. It can affect what medications we may or may not put you on. It can affect whether or not you have a different kind of osteoporosis related to poor kidney function. So we always look at that. We look at your calcium levels to make sure that they're in the normal range, so we're not going to drop them any more than what they are. We often look at your vitamin D levels. We routinely do that in everybody to ensure we're giving you enough vitamin D and that your vitamin D isn't too low. And then there's other more specialized blood tests that can be done. And there's differing opinions on the need for doing those or the validity for doing those. Or we might do more specialized blood tests if we're trying to rule out other causes of osteoporosis. So one of the things we do is if we can't figure out why you have a low bone mineral density, we may send you to rule out celiac disease, because in celiac disease, you don't absorb as much calcium. And if you've had that for a long time, it may weaken your bones, may lower your bone mineral density, but we don't necessarily do that in everybody. And then in terms of monitoring your blood or your drug therapy, often it's normal electrolytes, so the calcium, kidney function, those would be the big ones. Sometimes magnesium, but it just depends on the drug therapy. With Solodronic acid, the big thing is your kidney function. And then we just try and monitor kidney function in everybody because it really limits some of the medications we can use.
Okay. What is the recommended maximum length of time I can take the once weekly dose of Allegra or something similar?
So there is no maximum that I can say you cannot take it after this point in time, because if you are very high risk and you've had several fractures in your past, we would generally not recommend stopping that therapy. Kind of when we start to get worried is around 10 years, but again, it's really dependent on that. So if you've had, 5 vertebral fractures and you've broken a hip, I'm more worried about you breaking your other hip than I am about you having a rare thigh fracture. So it really depends on those other risk fractures. So there's no, you have to stop definitively at this point that I can give as a blanket statement.
Okay. Drug holidays is a big theme here today. Do drug holidays reset risk factors
Yeah.
for taking bisphosphonates?
That's the reason we do it. So what we think happens when you take bisphosphonates is you get, because your body isn't taking away that old bone, your bones can get a little bit, what I always tell patients, is a little bit chalky. Like, it's not that you have lots of bone density there, but it's not always great bone. Like, the structure of the bone isn't as best as it can be. So we hope to set that structure of the bone by stopping the bisphosphonate. So by stopping it for a couple of years, we can reset the structure of the bone, and then we can potentially restart again. So that's why we do it.
Okay. Let's try this one. Why is it necessary to not lie down after taking Resedronate if one drinks plenty of water?
Oh, because even if you drink plenty of water, you can still get the pill stuck in your throat. You might not even know where it isn't, like, it might not feel like it's stuck in the back of your throat, but it can still be stuck in your esophagus. So even if you're drinking it with a full glass of water, we still recommend not lying down, just in case it hasn't passed all the way into your stomach, just to reduce that risk of those esophageal ulcerations. So those little ulcers that can happen in your esophagus.
Oh, okay. What harm is done by discontinuing Prolia after 2 injections?
So the main risk of stopping Prolia after 2 injections, if you're not, so in this case, I'm going to assume you're stopping the Prolia and you're not starting anything else. So if you're just stopping the Prolia after 2 injections and not starting anything else, you could have a potential increase in your risk of those vertebral fractures. So we've seen in practice that once we stop Prolia, when your bones reset themselves, for some reason, it increases your risk of spine fractures. So often in our clinic, and again, it depends on individuals, we won't stop the Prolia without bridging people with another drug. So if we were to stop Prolia, we would often consider putting those people on bisphosphonate, so an oral drug, to bridge them to help prevent that massive decrease in their spine density, so that their spine bones don't lose that bone density we've built up.
Okay. When should I request to have a bone density test done?
So when you're on therapy, there's different schools of thought. We in our clinic, when we have somebody on therapy, we do it generally every 2 years, outwards to every 5 years. If people are on high dose prednisone or steroids, we do it every year. And then there's some physicians who put people on therapy and then don't do it at all because they don't think it changes their plan going forward. It also depends on your individual coverage in your province. So every province would have that differently. So we can't do it more often than every 2 years in most patients. So that's why we do that. If you've been stable for a long time, you might not need to have it every 2 years. And the other thing to keep in mind is, as we get older, no matter what we do, whether we're on therapy or not, our bone mineral density is going to go down a little bit every time we do it. So that's just something to keep in mind. In terms of as a baseline, I'm not sure actually what the current guidelines say in terms of that. We get a baseline in anybody we think might have a diagnosis of osteoporosis, but we don't do it in every single person we see either.
Okay. Lots more questions here. Let's try this one. Are there differences in managing osteoporosis between men and women?
Yeah, not really. The only major difference is, and I didn't go into this in my talk, you can use hormone replacement therapy in postmenopausal women to manage osteoporosis. So you can use estrogen to help prevent fractures in women who are postmenopausal, who might be at risk of osteoporosis or hip fractures or whatever. We don't use that in men. All the medications I talked to today, we use the same considerations for men as we do for women in determining therapy. So the only difference is that we wouldn't use hormone replacement therapy in men. We see a lot of men in our clinic. I think a lot of family doctors are often hesitant because they're not sure how differences are between men and women in managing osteoporosis. We also see a lot of men who get referred from our prostate cancer clinic because prostate cancer medications can affect your bones, but we manage them in very much the same way as women.
This is a general question. Is it possible to reverse osteoporosis through diet and exercise?
No, unfortunately not. I know, and it's so disappointing because when your bones become so bad that they're that brittle, it's really hard to reverse it. Our goal at that point is to maintain it, so to not let it get any worse. So that's generally our goal. Diet and exercise are very much important in helping. So like I mentioned, ensuring you're doing weight-bearing exercises that are safe based on what your bone mineral density is. So making sure you're not doing anything that can affect especially your spine. So some things, if you're doing twisting exercises, can be really harmful or potentially cause spine fracture. So that's something you should discuss with an exercise specialist or a physiotherapist. And then in terms of diet, I know there's more and more information coming out about protein and ensuring you have enough protein in your diet, because that helps build your muscles, and our muscles help cushion and protect our bones. But it's once your bone mineral density is low enough to give you a diagnosis of osteoporosis, we can't reverse it based on just diet and exercise alone.
Okay. And there is lots of information on our website as well for people that are interested in that topic. I'm just going to start looking at last questions here. So I'm going with calcium supplements, people are wanting to know if they're safe to take and if there's a level that they should cut them off because of side effects.
Yeah, so they are safe to take. They're kind of 5 to 8 years ago, there was some information out that they might not be safe to take, and that's been mostly debunked. We're fairly certain they are safe to take. We do still prefer it through diet, just because we think your body uses it better when it comes from diet than when it comes from pills. We generally don't recommend more than sort of 2 to 3 doses in a day. And we really try and maximize through diet as well. And like I said, there's really, really good resources in Osteoporosis Canada, because you can get it through diet and not just through dairy products, because lots of people don't like dairy products. So there are good hints there. I know our dietitian talks about using almonds and using beans and lentils and those sorts of things. But like I say, I generally don't recommend it more than 3 tablets in a day. That would be most, ideally 1 or 2. But we want you to get 1,200 milligrams of calcium a day in whatever form you can.
Okay. I think this will be our last question coming up, Teri.
Okay.
Are all the doses of medications the same for everyone?
Yes, which is weird, because that's not how it is with most medications. So it's not like we move up your dose or move down your dose based on your risk of osteoporosis. And I've never thought about that before, but yeah, it's very unusual in osteoporosis. So if you're on alendronate, you're on the same dose of alendronate that everybody else is on alendronate, unless you have a different condition. So these drugs can be used for other conditions and they can be used at different doses. But everybody who's on Prolia is on the exact same dose of Prolia.
Okay.
And these are not yeah, it's weird. And these are not medications that we generally, so some medications that you use for other things need to be adjusted if you have poor renal function and things like that. These are not medications we adjust in those cases.
Okay. Well, that was great, Teri. Thank you. Thank you so much. It was very informative, lots of great information. I just want to tell folks that this has been recorded and it will be available to replay tomorrow. And right now, I would like to let everyone know that for more information, please visit our website at osteoporosis.ca. There you're going to find our calcium calculator, some of our podcasts, our quiz, and as well as past webinars, which will provide lots of different information for you. Also, I would like to say thank you to all of you for joining us today, and have a great day. Hopefully we'll see you again soon. Thanks, everyone.